I am aware that there has been a big symposium on SGLT2 inhibition yesterday evening itself, but I'm sure there'll be something sort of make in India, made in India sort of ground. Now, and again we have a talk on SGLT2 just after me with Dr. Rajiv Chawla. There may be some amount of overlap. We tried to keep the topics as far apart as possible, but possibly there'll be some overlap. So what I would try and sort of cover is more of a general aspect of looking at the kidney and how SGLT2 inhibition could be useful. And I suppose Dr. Chawla, with his brilliance, will cover the clinical aspects even on a greater detail. These are the potential conflicts of interest. Now, we all know that our understanding of diabetes has come a long way. And we do know that it's quite different from what we knew in our college days. It's become more complicated. We understand different aspects of the pathophysiology of diabetes. It's not just the insulin resistance, the insulin secretory defect, and possibly increased hepatic glucose output, and we have increased to include increased lipolysis, contribution from the incretins in the gut. We have gone on to define a role for glucagon on the alpha cells. We have gone on also to talk about the kidneys, which will be sort of greater focus today. And then, of course, we talk about the neurotransmitter dysfunction, the appetite dysregulation in type 2 diabetes. And then we have various other nomenclatures added, the dirty dozen by our own Dr. Sanjay Kalra, to include issues like vitamin D, dopamine, renin-angiotensin system, and beyond that, treacherous 13 and faithless 14. So it is in an area of flux. At this point of time, we also are aware that diabetes management is not perfect. And that's partly probably because it is multifaceted in its pathogenesis or pathophysiology. And we have not been addressing all these different aspects so far. And we still know there is a progressive beta cell dysfunction which we have not been able to address satisfactorily. So you cannot have the same treatment effective across the entire duration of diabetes. And there are side effects, limitations, there are efficacy issues, and the result is only a small percentage of people with type 2 diabetes can achieve and maintain an ideal glucose control. And cardiovascular disease remains an issue. Whether the drugs themselves can prevent cardiovascular disease, or more pertinent immediately is whether they are safe enough from the cardiovascular point of view. And so we need new therapy. There is absolutely no doubt about it, and which should address glucose lowering without hypoglycemia. There should be little or no weight gain, and ideally it should also influence the fundamental disease process some way or the other. If we look at the oral antidiabetic agents, we do know they are effective, but we also are aware of the limitations. That's the reality. They have a limited efficacy. It's not effective over a period of time. Usually the efficacy falls off, so that eventually many of our type 2 diabetics require the support of insulin. Beta cell dysfunction, progressive beta cell dysfunction, is still not addressed adequately by any of these agents. We know drugs do have side effects, hypoglycemia, weight gain, and ideally, anti-diabetic agent in type 2 diabetes should also have favorable effect on blood pressure, on lipids, on kidney function, and so on and so forth. That would be sort of utopia. And long-term cardiovascular safety is something that I was mentioning is not there. So there is a gap between expectations and reality. Again, if you go to the beach, of course, one would expect that you maximize the effect of sunlight and build up your vitamin D stores, but the reality could be different because of various reasons, social maybe. Now, we'll pick up or pick on kidney as one of the missing links in the pathophysiology of diabetes. And we also talk about the apple. An apple a day keeps the doctor away. So what's the link between the apple and the kidney, or for the matter, SGLT2 inhibitors? Well, of course, if we go back in history, we do remember that it was FLOZIN, which was the first agent which had SGLT inhibitory property, though at that point of time in 1835, SGLTs as such were not identified, were not known. But this was identified from the bark of apple tree. And then, of course, much work has gone through, and only in the 90s, 70s to 90s, actually, these transporters were identified, the sodium glucose co-transporters. And later on, the earliest attempts to develop an SGLT2 inhibitor for use in diabetes was in 1999, a compound given a number T1095. However, it was discontinued in phase 2 clinical stage itself because of lack of enough bioavailability. And then, of course, we know the story of the FLOZINs being accepted, approved by different bodies across the world. The first to be approved was dapagliflozin by the European Union in 2012, but the first in India was canagliflozin late last year, and we also have access now to dapagliflozin, which was approved earlier this year. And of course, empagliflozin is also knocking at our door in India. So when we think of kidney in terms of glucose homeostasis, it has multiple roles. Of course, it filters glucose, we know. It reabsorbs glucose. It uses glucose also. It's a glucose-using organ, but it also produces glucose. It can also contribute to gluconeogenesis. And it's interesting to know that there is some sort of crosstalk between the liver and the kidney. If you think of the postprandial state, we all know that endogenous glucose production overall comes down significantly. And this is primarily because the liver shutting off its glycogenolysis, significantly decreasing its gluconeogenesis. But at the same time, as the liver shuts off in the postprandial state, the kidney takes over and produces more glucose. And so it accounts for about 60% of endogenous glucose production in the postprandial state. And so there is sort of compensatory role between the liver and kidney. And that's also something that we need to remember when we talk of SGLT2 inhibitors, where we are sort of decreasing the contribution of the kidneys to glucose pool in blood. It is now recognized that SGLT2 inhibition is associated with increased hepatic glucose output, and that partly sort of nullifies or decreases the effect or efficacy of the SGLT2 inhibitors. So we all know that at about 150 to 180 grams of glucose are filtered each day, but very little comes out in the urine, and that's because of the efficiency with which SGLT2 mostly, and to whatever is left behind after SGLT2 absorption, reabsorption of glucose, it's mopped up by SGLT1, so that very little glucose appears in the kidney. And this is just a diagrammatic location to show that the SGLT2 is situated more proximally in the proximal convoluted tubule, while in the same proximal convoluted tubule just beyond the location of the SGLT2 are the SGLT1. And we do remember that SGLT1 is primarily present in the intestine. It's also present in the kidney, but primarily it's in the intestine. And that it has a high, SGLT1 has a high affinity but a low capacity for glucose, and it's not specific for glucose, it also is associated with galactose transport. Now, when we talk of SGLT2 inhibitors, the various clinical trials, we are reminded of the experiments that nature had set up a long time back. Individuals with renal glycosuria, familial renal glycosuria, who excrete more than 100 grams of glucose every day in urine. And at least that gives us an assurance that this sort of inhibition or lack of action of the SGLT2 is not fraught with significant adverse events. These individuals are generally healthy. They are only picked up just incidentally. They do not have significant problems of fluid loss or electrolyte disturbances or even of urinary tract or genital infections. That apart, there is a condition of MODY3, one of the types of MODY, which is also associated with decreased action of SGLT2, thereby causing increased glucose excretion in urine. Even that is a relatively benign condition. Moreover, to put in perspective the role of SGLT2 inhibitors in diabetes, we now know that SGLT2 is upregulated in diabetes, both in type 1 and type 2. So you are actually addressing a pathophysiological defect in type 2 diabetes when you are inhibiting SGLT2. And of course, because we want the kidney to be the primary site, we want SGLT2 to be the main, the inhibitors should be specific for SGLT2, otherwise you will be blocking galactose absorption from the intestine also to a significant effect, and that potentially can give rise to more side effects. However, we shall come back to this issue in a little while. And through decrease in glucose levels in blood, they have the potential also to improve insulin secretory defect in the beta cells and also peripheral insulin resistance. Of course, these are not the primary mechanism of action of this group of drugs. Because it involves excess glucose loss in urine, that is loss of calories, it has also, these group of drugs have the potential to cause some weight loss. And similarly, because it is a sodium glucose co-transporter, so it's not only glucose, it's also sodium that comes out. So that could also help in blood pressure reduction to a small amount, to a small extent, and so could have a facilitatory effect in hypertension. So if we sort of look at altered glucose homeostasis of the kidneys in diabetes, there is increased gluconeogenesis, producing more glucose, there is increased glucose utilization, and there is also increased glucose reabsorption, and this has been shown very elegantly by studies that the SGLT2, this transporter expression is more in the kidneys in diabetes, and overall glucose, cellular glucose uptake is also more. So we try to block this abnormality and get more glucose out and help to get the glucose down. So far so good. So these have important sort of preclinical effect to have potential for use. But do these agents serve the purpose of glycemic control in type 2 diabetes? Well, there are a whole lot of studies. I have quoted some. These are from dapagliflozin because much of the earlier studies and possibly the largest amount of studies with dapagliflozin. However, all the others, canagliflozin and empagliflozin, have very similar effects. So they are effective in terms of HbA1c lowering. Sorry, these may be too small to read from the back, but roughly it's something from 0.5% to up to maximum maybe 1%. Of course, if you start with a very high HbA1c, the decrease in A1c will be even more than 1%. They decrease fasting glucose. They decrease body weight, and this has been shown to be consistent even over 1 year, even over 2 years, to an effect of maybe anything between 1.5 to 3.5 kilos. And they also tend to cause a little bit of, actually cause blood pressure lowering, systolic pressure lowering of about 2 to 5 millimeters of mercury. So actually the things that we expected are shown to be true in clinical trials. Now when we talk of, we want the SGLT2 inhibitors to be very specific for SGLT2 inhibition and not have much to do with SGLT1, but actually all the compounds have some spillover effect on SGLT1 as well. The most specific is empagliflozin, then it's dapagliflozin, then it's dapagliflozin, then it's ipragliflozin, and then it's canagliflozin. So canagliflozin may be slightly less specific. However, that may sometimes give an advantage as well. Because this SGLT1 in the intestine is also blocked, and if the drug is administered before a meal, it could immediately block the postprandial rise in glucose levels through some effect on the intestinal glucose absorption as well. Normally, a drug acting through the kidney will not lead to an immediate effect on postprandial glucose levels. However, canagliflozin does have. And this may also translate into slightly higher, which may not be clinically significant, higher efficacy for canagliflozin compared to maybe dapagliflozin. However, overall, there does not seem to be a great deal of difference in terms of efficacy amongst the three different agents. We, of course, are talking of type 2 diabetes. In type 1 diabetes, there are a number of studies, ongoing studies, which show that they may also be effective, of course, on top of insulin, not in lieu of insulin, because its action is insulin independent and could lead to lower requirement for insulin and therefore lower risks for hypoglycemia. So it could be potentially used in future in type 1 diabetes also along with insulin. Now, as we were mentioning initially, the FLOZINs, they are not just glucose lowering agent. They could have beneficial effect in terms of body weight, and this body weight loss has been demonstrated very elegantly through DEXA studies with dapagliflozin to involve primarily loss of fat mass, not loss of lean body mass, and not just because of fluid loss. Secondly, reduction of blood pressure. We now are tending to understand the mechanism because it causes salt loss. It could cause lowering blood pressure. Apart from that, because sodium is also not being allowed to be absorbed, there is more sodium delivery to the juxtaglomerular cells. And the juxtaglomerular cell senses it and readjusts the renin-angiotensin system so as to cause this deactivation of the renin-angiotensin system, which also could have a beneficial effect, not just blood pressure, could even have a better effect on cardiovascular outcomes. But of course, this is conjectural at this point of time. Apart from that, because of effect on the renin-angiotensin system, it could also have favorable effect on renal hyperfiltration, has the potential to favorably influence renal function as well. It does cause reduction of uric acid level. And so overall, these group of agents do have the potential to reduce cardiovascular events. But of course, does it mean that today we have solved all the problems of diabetes, type 2 diabetes management with the availability of SGLT2 inhibitors? Of course, I wouldn't like you to get away from this all with this idea. And these group of agents have their own limitations, the most important of which, of course, these are new agents, these are exciting agents, but naturally it means that we have relatively less experience with these agents. We do have elegant studies, 24-week studies, 52-week studies, 104-week studies, but that's 2 years. But you are going to treat a type 2 diabetes for 25 years. So is it safe enough? We do not have the answers yet. Even whatever short-term studies we have found, it does show that it increases the urine output, which means it does increase volume loss. So it could lead to dehydration, especially in a hot climate like ours. It can cause transient decrease in GFR, which has particularly been shown with canagliflozin studies, initial transient decrease in GFR, which, however, stabilizes at this maximum at about 3 weeks. But if you see at 26 weeks, the GFRs are back to the previous state. There is the potential for electrolyte disturbances. Loss of sodium could be an issue. And most of the studies have shown that they can be associated with slight increase in LDL levels. LDL is something that we sort of hope to keep under control from the cardiovascular point of view. But most of the studies, and maybe it's slightly more for CANA than for DAPA, but most of the studies have shown small increases. The saving grace, of course, is that it's also associated in increase in HDL level, so that the LDL-HDL ratio is not significantly altered. But we have to keep this in watch in future. And then, of course, there are issues with higher risks of urinary tract infections, definitely higher rates of genital mycotic infections, especially in women. And with dapagliflozin studies, there have been some suggestions of increased fracture, numerically slightly higher incidence of fractures in DAPA-treated patients compared to others. There have been other studies which have looked at bone density with canagliflozin, for example, which have been reassuring, but still this is something that we need to think about, because this may not be evident in 1 year or 2 years, may be evident 5 years or 10 years ahead. And then, of course, I put double queries against malignancies. These were issues initially, bladder malignancy, breast malignancy. There were slight numerical imbalances shown with dapagliflozin, but I feel at this point of time, we are fairly assured that they are not associated with increased risk of malignancy. But again, we need to keep our eyes open to see what the future holds for us. And then, of course, in terms of cardiovascular safety, there are ongoing studies. There's one with CANA with about 4,300 subjects. There's a much bigger study with DAPA with 17,000 studies, and we will wait for definitive answer to their cardiovascular safety from these studies. And then, of course, these are agents which act on the kidneys. These are agents which cause the primary efficacy is because of renal glucose loss. So kidney function will be critical to their efficacy. So if you have significant renal impairment beyond CKD stages 3, the efficacy is likely to be less. The product inserts abroad for CANA versus DAPA suggest maybe CANA may have an edge in being efficacious even up to an eGFR of about 45 ml, whereas DAPA would be at about till about 60 ml. Though though the Indian product inserts suggest that it's good even at eGFR of 45. And of course, pregnancy lactation has never been tried. Elderly subjects, preferably, we would avoid because of slightly higher risk of dehydration and dyselectrolytemia. So what's the current position? Of course, in 2014, the ADA-ESD guidelines didn't have a place for SGLT2 inhibitors, though the ACE, the American Association of Clinical Endocrinologists guidelines did have. But in 2015, they are there, SGLT2 inhibitor, beyond metformin. You could use SGLT2 inhibitors. Of course, intermediate efficacy, low risk of hypoglycemia. They cause weight loss. They cause genitourinary infection, dehydration. Of course, they are very costly. So these are the issues with this. So finally, take-home points. We do know there are multiple defects in type 2 diabetes. We do know that we need to address multiple defects, especially for cardiovascular risk reduction. And we have an agent which acts in a beta cell independent mechanism and does not cause hypoglycemia, complements the action of other agents, and could actually improve glucose control with improve in other properties. So, ladies and gentlemen, here we have really a new dawn, the SGLT2 inhibitors, especially in the disease cluster of obesity, hypertension, diabetes, and its insulin-independent mechanism of action. But we do remember that optimum management of type 2 diabetes is multifaceted. It's not just glucose control, and there are many other agents for glucose control as well. Thank you very much.